first, to prevent this complication, a balloon-assisted stenting is sometimes useful. Just put a balloon, even in the left main, like a pot, and then pull the stent against the ostium of the to avoid this protrusion. This is the first comment. The second comment is that why did you choose the string? Because if you have a protrusion, you can go distally. More distally you go close to the carina, the better it is. Why only one string and not the more distal part? Because it becomes like a provisional. You have to oppose more strut to the other part of the vessel.
Yeah. So thank for the question. I agree that so about the first question, I think that your technique is a valuable option. What we try to do is not something that I use in daily routine. In case of trying to nail the LAD ostium, I prefer to pace on the LAD wire at very high rate, try to stabilize the stent, but your technique is also a very good option. For the second point, I think that we analyzed by angio that the protruding part of the megatron was very short, 1 or 2 crowns, and so that's why we went for this string technique and try really to avoid as much as we can any presence of struts within the left main, because the left end was very large. But I think that there will probably there are different options to treat this situation, and the string is just one strategy we decided to choose.
I ask because I noticed by OCT that there was a remaining neocarina in the middle, so you didn't move this neocarina. So the best choice would be to go to the very close to the carina with the wire. Don't the purpose go in the last string, but just go to the carina and remove the possibility, avoid the possibility that there was a remaining neocarina after the string. This is because at the end, the OCT demonstrated that there was a string plus a neocarina. So there was still a predisposition to stent thrombosis.
Well, I understand your point. My feeling was that the length of protruding after the string and the neocarina was pretty short, and I think that really our goal was to avoid any placement of a second stent, and we didn't want to convert into a culotte. But I think that, and once again, that was not the initial strategy. That was our plan B, because our plan A went wrong. So, but I think that your suggestion is also very valuable.
And final question: did you think about to crash the LED stent and then doing kissing and just like a mini crash, but without the choice to put a stent in the left main? Just crash, to have a mini crash, do a kissing, and then finish without protrusion.
Yes, so this is correct. That was one of our option, and we discussed with my fellow about what was the best possible strategy in this case of bifurcation with a very large left main and large discrepancies diameters between main vessel and my main and side branch. So, and we felt that, and it's only a feeling, but that crushing will be a little more challenging to get a proper result, especially in this 20-year-old woman with diabetes. And so we tried once again. We felt that there was already too much metal in this left main and tried to avoid. But I think that definitely the crush was also an option.
Yeah, because the left main was big. If you crash in the roof of the left main, mini crash there. It's like an internal crash sometimes in this big vessel compared, because it's very difficult to expand to 6 millimeter, because you have 3.5. You have to reach the other part of the left main in the polygon of confluence. It's very difficult to expand more than 6 millimeter. So you will never reach the other part, especially if the circ is without a plaque to oppose the stent.
Sure. I mean, if I would have a smaller left main, like a 4.0, 4.5, that definitely an option I would have considered.
I mean, Nicola, the case is a great one. I'm really interested by the fact that it was a Megatron. And I commented on the Twitter stream that, you know, of all the stents, actually, because the Megatron's been strengthened at the front end with 4 linkers on the 12 crown stent platform, if anything, it's probably less capable of string than some of the other competing stents. So it's pretty impressive to see how far you were able to expand that device. But I do wonder whether the string might have been more effective had it been an alternative kind of standard coronary stent. I don't know what your thoughts are on how the stent design impacts on your ability to achieve the result.
We have been using Megatron for now 8 or 10 months in our cath lab, and so we were really able to challenge it. And actually, we also noticed that the overexpansion capacities of the Megatron are really very good and probably better than reported by the manufacturer and by Boston Scientific.
Yeah.
So usually
although that's to be fair,
I'm quite sure that in my experience, I'm not sure I would have been able to get this result with another stent.
Okay. But I mean, clearly the overexpansion capacity is down the central lumen of the stent. So the ability to go to 6.7 or maybe beyond is clear. But through the side of a stent, where actually the cells are smaller in the Megatron in principle, because you've got that 4-linker technology.
Yeah, but I think I just feel that you can really overexpand pretty nicely the cells compared to the previous the previous Synergy device, and probably with other competitors. It will be quite interesting to, you know, that Nicolas Foin was always doing this bench test, and I would be very interested in the updated data with the Megatron, and if we could find any significant difference.
Yeah, that's
good. It's one of the, hello everybody, first of all.
Hello, Nives.
Actually, it's one of the things that is claimed from the Megatron, is that you can really overexpand it. So it's one of the advantages, apart from resistance to longitudinal deformation. The other potential advantage was this capacity for overexpanding it to a higher level than the previous Synergy.
And so are you using, you say that you've embarked on using Megatron more so in the last 8 months. Are you using it for all left main?
Not all left main, but no very clear alternative to over stents in left main as the first option. I mean, before Megatron, I almost never used the Synergy in the left main because of all those concerns regarding the longitudinal compression, and also I think that if you go over the IFU, the sizes of the stents and their overexpansion capacity were definitely not as good as other competitors, especially the Xience. But now with the Megatron, definitely Boston Scientific closed the gap and proposed really left main dedicated stent that could be used, of course, in other situations. But that is really a nice one, and I really like the design. I like the strength of the stent, the stretch, the cell. I mean, everything has been improved in my experience, and I have to say that my only limitations now for really using the Megatron in large left main are the size of the balloons. We need bigger balloons, I assume. I mean, in our case, we use a 5.5 per 15 millimeter balloon to overexpand that, because that was the only that was the only large balloon that we had in the cath lab. So we need really.
I think that's a very fair point. There's definitely the need for bigger balloons over a greater matrix of balloon length as well.
Yeah.
Tom, one point that needed to be addressed is when you open up the cells at the extreme level, what about the drug elution? Do we have enough data to show that it's going to be the same and you are covering the local response? What about the protrusion? It doesn't matter. Do you have any type of data on that?
Tom?
Well, I mean, I think you talked about the IFU. What Nicolas has done is far beyond the IFU for the device. So you'd have to consider that overstretching the device is going to result in some disruption to the abluminal polymer on the stent. I'd be very surprised if you haven't. But it's less about getting the drug in the vessel. With such a large vessel, even a small amount of neointimal ingrowth is not going to impact on that stent, I would argue. The greater issue, as Remo said, is probably the stent thrombosis risk long-term in terms of a failure of healing rather than aggressive restenosis, I imagine. So I guess that turns to what do you advise in terms of antiplatelet therapy long-term? Is this a patient now who has to have long-term antiplatelet therapy because we've got scaffold that wasn't anticipated into the left main?
Well, the good point is that actually for this patient that was quite straightforward, because as I mentioned in the presentation, she was 28-year-old. She had a really low risk for bleeding and a very high risk for recurrent ischemia because of left main, because of diabetes and multi-vessel disease. So according to the guidelines, this patient should definitely undergo DAPT duration more than 12 months.
Yeah, I think that's very fair. That's a great case for discussion.
Thank you. Thank you.